Welcome to NeuroNoodle's Neurofeedback and Neuropsychology Podcast, featuring tech legend Jake Gunkelman. He's the man who has read well over 500,000 brain scans, and Dr. Mari Swingle, author of iMinds. Our goal is to provide information and promote options for better mental health. The NeuroNoodle Podcast is supported by listeners and businesses just like you. A lot of kids are starting school now, and there's a certain amount of anxiety. I wasn't anxious, I just didn't want to go. But you know, parents are going through it, kids are going through it. I thought it would be interesting, you know, how to deal with it other than kicking them in the hindquarters.
Well, I mean, we can just start talking, you know, where we left off last week. You know, the term anxiety has become a big, scary term. You know, but a little bit of functional anxiety, that nervousness, that excitement about the first day of school. You know, when you're an adolescent, it's about what shoes you wear. You know, when you're a kid, it's about who's new in the class. You know, but there's also, hey, is that bully that was there last year going to be here this year? Am I going to do well? Am I going to make friends? You know, all of those looming questions. And I guess it's a matter of how, as you know, people who work in mental health, parents, educators, help kids to mitigate those emotions, help them to share with them how it's completely natural to feel expectations and how some of that is nervous. And, you know, where and how and why we go right down that anxiety path, that mental illness path. Jay, do you have any comments on that?
It's easy to mistake excitement for anxiety.
Yeah.
You know, they both are increased arousal states, but it's how you frame it more than the state that you're in. Mm-hmm. That said, it takes quite a bit of knowledge or teaching to get somebody to understand the reframing. Because it's so easy to fall into the trap of it, you know, whatever the little heart aflutter is anxiety. It's normal to feel Pete before the game, all excited to get in and do it, you know. So that excitement's easy to mistake for anxiety. Yeah. But there is a problem with anxiety, and our healthcare system, which is the biggest misnomer in the world, you know. It's not really very systematic and it doesn't promote health very well. So,
well, I know we talked about anxiety last week, gals, but kind of where I was going with it is you have in the States, you have preschool, you have middle school, then you have high school. Yeah. There's a different level of unforeseen circumstances that kids got to go through. Can you guys address like what's going on in each one? Like high school and first grade, I mean, it's two different things. High school, you know, you're a freshman.
Well, I think the little ones, you know, you're talking about, if we want to go back to the term anxiety, separation anxiety. But I do want to frame that as, you know, for, I would say, certain portion of children, just based on personality. You don't have to tell any parent that a child is born with a personality. You know, some children are terrified of leaving the home and going out and being quote unquote independent for many hours. And others just race. They don't even say bye. You know, that this is the natural range of human and human states, traits, personality. But where does the mental illness fall into that? Where is a reaction to extreme? And I would say for a 3-year-old, there's no such thing as an extreme reaction, because these are the years where you're figuring all this out. These are the years when the personality is starting to blend in with the environment. And that's where I really believe in training of parents, whether it's family training, community training, professional and training, innate training, you know, being one with your child and figuring out, okay, when is this the perfectly natural next step in life, and when is it too much? But I mean, to loop back in as we get a little bit older, you know, we can talk a little bit about what's natural and not natural, but we can also stick those electrodes on, right? After a certain age, we can see when the arousal starts to flip into a negative arousal. And then we can kind of make some choices as to whether we want to coach the environment, whether it's the parents or the child with a little bit of counseling, whether we want to get right in on there and train the EEG, or a combination of both. My only reticence here, and of course I always get myself in trouble or not, is wait on the pills, right? Don't start medicating before you have an idea of what's going on in the environment in the brain. And I think we're medicating so early. I don't know whether I've said this on this show, but let's just pick a 4-year-old.
Or an 18-year-old going to college. They're starting too.
Okay, well, I don't know. I was going to make a comment on bipolar. When you have a 4-year-old, screaming, about something, they drop their ice cream or whatnot, and then just bouncing into happiness because they see a little puppy. That's not bipolar. That's a child. But yeah, when those type of mood swings start to happen in adolescence, is that something we need to look at with the EEG, or is that hormones? There can be so many causes.
The development in the EEG is, I think, very interesting as to follow along where you started with separation anxiety as an example. You were talking about 3 years old. Well, Alan Shore talks about the development of emotion, the primary emotion, right frontal and right amygdala. But at a year and a half, 2 years, when separation starts to happen, of pathological separation can end up with social emotion in the left structures, the amygdala on the left side, the temporal structures on the left side, where shame and guilt, which are they're learned emotions. They're not innate, like fear, anxiety, the joy. I mean, the primary emotions. But these secondary social emotions end up developing on the left hemisphere. You can end up with enough disturbed genetics that bipolar may be an issue, but it's really strongly genetic. There are gigantic beta spindles frontally in classic bipolar, and you can see them earlier in life, but they haven't started the cycle enough to be diagnosed. There's a lot of, diagnosis. That's a whole can of worms unto itself. Just set aside the DSM, that they're not diagnosed bipolar until they start to cycle, and earlier on, they're usually classified as hyperactive, and propensity to have that kind of a disorder is seen in the EEG early, and you can intervene early to avoid the pitfall of starting to cycle. If you can avoid the super high, you can avoid the collapse into the depths. You have to learn fairly early on to control those beta spindles, and they can be massive. Spindling excess beta was described by Gibbs in the early 1930s, but one of the nice things is Niedermeyer. Unfortunately, he's passed, but his big, thick treatise on EEG, along with Lopes da Silva, clinical electroencephalography, they talk about spindling excess beta, and they quote the Gibbs obviously as the source, but that they quantify if it's bigger than 20 microvolts of beta spindle, it's abnormally large, and that's easily kindled cortex. The beta spindles that get really big are the tonic form of tonic-clonic seizure. So these beta spindles can be very, very problematic. And bipolar, that's the classic thing that we do see is beta spindles. And group average is greater on the right frontally. But group average is a terrible way to characterize an individual. And I've seen frontal beta skewed to the left in somebody who's grossly bipolar just as easily. So you got to take into account that that group average you have to look at the variability within the group to understand that you can have some outliers on the left side. It's still the same presentation.
Jay, how young would you recommend we start to have a look? Because I always fight in terms of, kind of let it be. Let's not pathologize this little person.
Oh, we don't have to pathologize
and
EEG.
What kind of is your age where you recommend that we really have a look? Like, when is there a perfect time? Is there we're going to miss it if we don't get on it? Of course, we're playing with the epigenetic notion here as well, but if, for our listeners out there,
about the time that they're interested in cartoons on television and they can track a storyline, they're capable of doing the kind of feedback that's just generic, and their EEG can guide a lot of just routine. You don't have to pathologize it, but if you set up a whack-a-mole game for kids, that's a CPT task. How many commission errors where they whacked where there wasn't something? How many omission errors where they missed something that they could have whacked? And what's their reaction time? You can have finger tapping and get laterality. There's all sorts of games that you can do that end up guiding people. If you're slow on the tap, you can go and play this game over here, which ends up fostering motor development. If you're really bad with omissions and commissions, you can go do that brain game and learn how to control theta and alpha and beta. And at that point, you haven't diagnosed anything, but you've avoided the problems of later life ADD by getting rid of the frontocentral theta or the frontal alpha excess. You've fostered better affective control, and you've intervened with them fairly early. And again, this is set up basically as gaming, and that if you're really good at this game, you don't have to do that, but if you want, you can. I mean, you set up a game room for the kids, and preschool, kindergarten era, you can start to actually separate out some people that end up having to have their EEGs looked at a little bit more completely. And those are going to be identifiable based on outlier patterns. The people that are looking at the simple EEG data can kick out somebody for a more complete scan. The incidence of unexpected epileptiform discharges in kids is tremendous. In autism, 60% or more of the autism have epileptiform content in the EEG. If you stabilize that, they really, really, really improve. If you don't stabilize that,
there a little bit. This is one of the things that I've been kind of wondering about, just yip-yapping with my colleagues about. We know that the prevalence of autism has just escalated incredibly over the past 20 years. We also know, as you said, the association of eleptiform and autism. Do you have any thoughts or theory in terms of the, not necessarily the increase in autism per se, but the increase in eleptiform in all of us as a race, so to speak, or are we just only capable of seeing it now? So how typical is
we're only now doing the testing? If you look at classical EEG, 1950s, 1960s, 1970s, 1980s, 1990s, literally EEGs weren't collected. EEGs was for epilepsy and encephalopathies of some, altered consciousness of some sort. But autism wasn't an EEG thing, and neither was ADD, neither was depression. All of those kinds of things didn't get EEGs, which is right now one of the issues. They like AI to replace psychiatry, but they don't have the data to train the AI because they didn't collect the data on all these kinds of things. They have epilepsy covered, they have gross encephalopathies covered, degenerative dementias covered, but that that doesn't really characterize the breadth of psychiatry. So their hope that AI would kind of solve the DSM was a pipe dream, you know. And they actually asked an AI what it would take for AI to be able to read EEG clinically and neuropsychiatrically. And the AI basically gave this answer as it's going to take about 4 years. It's going to take a team of experts in EEG and experts in AI and experts in programming and all of these working together and access to the data representing the general population.
Yeah.
Oh, and how much data? Oh, at least 500,000 or more. Yeah. And I'm thinking, yeah, that's about right. You know, I put 500,000 under my belt before I thought I had some clue what was going on, you know. So, but you know, it will happen, but it's going to take a long time. This is not the, you know, I've got the AI algorithm. Where's the data set? You know, they don't have the data set. In fact, Emmett Aitken, the head of the AI project out of Stanford, spun off into private, but he started out at Stanford. And he came and said, you know, we were all excited. We had 37,000 EEGs already digitized and available. And I said, oh, yeah. All epilepsy and encephalopathy. He said, yeah, I know. So he wanted access to, you know, he heard I have lots and lots and lots of data, which I have. And I said, I'm sorry, it's not mine to give to you. And it belongs to my clients and their patients. And that's, you know, there's no way I can give you access to that. Mm-hmm. And I introduced him to a couple of my big customers to see whether they were interested in, you know, having them go through and get permission from the clients to have the data used. But that, I don't know how that turned out. You know, that's all contractual access to data and gives you access to the outcomes and stuff. But,
yeah, I was going to say we're at a really interesting crossroads, I think. I mean, we all know, you know, data in or garbage in, garbage out, the saying in data. And I'd say like now a lot of individuals are contributing to the body of work, you know, the full cat cues. But you know, here comes Dr. Mari on her soapbox, but you know, the way the data is cleaned. And this is where I really, really speak to AI versus AI, which is my, you know, my newest catchphrase of artificial intelligence versus assisted intelligence. And I think we have to be really, really cautious about where this massive data set is going to come from, and who's managing it, who's artifacting, who's cleaning it.
Getting back to first day of school, we've recommended EEGs for athletes that are very serious about their craft. Well, what about students that are very serious? When do you think parents should get an EEG for their child, their adolescent, their teenager, you know, going to college? Not to get it diagnosed, but just to have it as a backup to archive in case something comes up. Would you treat a student the same way you would?
Or alternatively, as a base recording, guide you for what might optimize them in the short run. Yeah. The database is very, very young. The breadth of how wide the variability is that's still considered within the norm is so broad that's essentially pretty well useless. But about age 6, 7, the norms all kind of congealed together. The developmental variability is kind of stabilized. So at about 7, 8 years old, 6, 7, 8 years old, somewhere in that range, you could get an EEG. The normative comparison would be fairly stable, and it could tell you, you know, frontal alpha hypercoherence, maybe some affective regulatory stuff you could deal with now before it's a big problem. There's frontocentral theta, dopamine deficiency in the striatum. You could use methylphenidate, or you could learn neurofeedback. They give them the options for how to optimize or deal with the phenotype that they end up with. The phenotype is like the hand you're dealt in poker. They're genetically linked, and you might have a couple of different phenotypes, combined. But there's a way to play every hand, and a way to optimize your outcome if you're given one of these hands. So
I debate this one all the time, and if I can just go back historically in terms of how I got into the clinical component. I started as an educator, and I was actually working in accelerated learning. So, and before I merged with Dr. Swingle Sr., I had my own practice called Peak Learning. And I switched over to clinical, yes, because I was fascinated by it, but also because of the clientele that I was working with. Accelerated learning for kids is fantastic. But I think we can kind of also pull this in with athletics in terms of what's too much, too young, how good is good enough. And if we look back right into, anxiety, you have a whole, spectrum of parents who really, really, from the best, pure space in their hearts, want their children to really, really not just succeed, but excel. But there's this push mechanism. So sure, you might have a little too much slow wave activity, and we can sharpen you up to have you perform better. But when does it become too much? And when do we become part of the problem? How much, what's the fine line between super sharp and an anxious mess? And that's where, again, I went back to school and I started studying the clinical, as I said, because I thought that we could do much, much more good in that. And in fact, there's a danger in the harm of too much wanting to make super people and making people super unhappy.
There's a big contribution from Judith Lubar, bless her heart, she's passed.
Yeah.
And it was that if you're working on a kid for ADD or anything else, you should have family therapy going.
Yeah.
Because the apple doesn't fall far from the tree. And, you can have an obsessive parent pushing a kid, and, you've got to deal with that dynamic. That would be the strange attractor that would make them bad back into their old pathological ways without an intervention. So, it's good to get started looking at the EEG again when it stabilizes 6, 7, 8 years old. It's a good time to start. And at that point, you can optimize. And again, family dynamics being what they are, you may end up finding yourself needing to bring in a little family therapy on some of the cases. But optimizing is not that difficult. And once kids learn the additional control, it's a skill set that they have. And they get better at it with time, even with no further feedback. And they've shown that very nicely out of data, a 10-year follow-up, 6 months, 12-month follow-up, where from pre to post, there's a certain amount of gain, but it consolidates further with use. Again, it's a skill that you've learned, and if you use it, you develop it further. So, the EEG training ends up having unexpected spin-off of the knowledge of self-control. The locus of control is where? It's right here. That's when you know that you have control over that. It's empowering in a way that you don't get from a lot of other things. It's across kinds of therapy in neurofeedback. The people that learn control over the brain end up having a self-control, self-regulatory perspective. I think that's been altered in a good way.
You're making such an investment of time early on, and the kid is setting a foundation for future learning, and you have an impedance there. I would think you'd want to know what kind of clay you have to work with before you start shaping it. Because if there's some disability, dysregulation, whatever you want to call it, knowing that it's 6, 7 years old is better than yelling at your kid for not understanding or going through all these problems, and then the teenage years, kick in. I can't believe they don't ask this to be done with it. They make a kid do a physical, right? A student, to go in. I don't know why they want to say, hey, oh, wow.
Well, that part is easy, Pete. That part is really easy. And nobody's going to disagree with that. It's the other side that we have to be a little bit cautious of, in terms of, what are you training out and why are you training out? I mean, the classic is drive. Okay. The same region of the brain, the same measures, can turn into obsession or can turn into drive. This is where I talk a lot about direction versus correction, and what is the ideal age? If we go into young, are we going to be taking away that drive? Or if we go in at the exact same age, it's an absolute blessing, because we're really helping the person out. So I think that's where every single one of us has to really have our own thinking caps on.
Well, those people that have their own thinking caps on, 8 or 9 out of 10, they're saying they have ADD.
That's my point. That's my point.
So,
these kids,
so if you have an EEG, you can weed that out, can't you?
And ADD is not one thing. ADD, ADHD is not one thing. Dr. Kropotov basically suggests a hyperactive kid comes to your door, and they could have this presentation, that presentation, the other presentation. So they could have frontal theta, they could have frontal beta, they could have frontal alpha. They could have epileptiform discharges, which about a quarter, maybe a third of ADD, ADHD kids have epileptiform discharges with no seizures and are undiagnosed because EEG hasn't been looked at. And the thing is, if it's an epileptiform discharge, it doesn't mean that it can't be treated. My work with intractable epileptics who are having hundreds of seizures a day, out of control, meds don't work, they're being proposed for brain surgery to cut out a spot. Well, epilepsy is a network problem. You can't cut out a freaking network. So their success rates are not so hot. They have an approximate 50% success with brain surgery, where they took out a big chunk of the temporal lobectomy. Now that they go for a little lumpectomy in the temporal lobe, their success rates drop down some. But they do offer to go back in and take another lump, but you can't cut out a network, but you can train a network. Yeah. And we've taken intractable epileptics and trained them so that they don't have seizure discharges anymore. They have a clean EEG and they're asymptomatic and they're off of meds for many years and their brains being optimized. Isabella was a case we just published with her permission, with her name in it, and she's presented at a meeting about her outcome. She's seizure-free now for 7 years, and she just graduated with honors at Baylor with a tennis scholarship, full ride tennis scholarship. So from being unable to do self-care to being a Division I ranked tennis player, and little Maggie, who had a video shot about her, and the parents are open about her case and identifying her and everything. Maggie just had another routine EEG. The doctor hasn't come back in routinely. I mean, she had intractable epilepsy, and they just did a clinical EEG with 24 hours, with everything all wrapped on, and they said, perfect. This is a perfect EEG. So, which I've never seen a perfect EEG. There's usually some artifact here and there and stuff, but nevertheless, perfect meaning no epileptiform discharges, I would agree. And she learned how to stop having them. And people were kind of trying to congratulate me for the work, and I said, no, Maggie did all the work. If there's something that didn't happen right, that's my fault. But if there's success, the client did all the work. This is the computer feedback and the client. This is not me ratcheting on something. This is basically a client in relationship to themselves through the computer feedback, learning how to control themselves. Who came with a manual? This is learning how to control yourself in a way that most people think is not possible. Ask a neurologist, is it possible for people to control their brain activity? Good luck.
Well, the change is coming from a bottle, isn't it? Let's take a junior high school student that's got to take a placement test to decide, what college you're going to go to. And then they get into the college. It's easier to get Adderall in college than it is Tylenol, right? So,
and Tylenol will kill you. In
the 80s.
Oh yeah, drinking and Tylenol together will kill your liver, and students don't. They're going to be drinking and having a headache and taking the Tylenol. So,
well, my point is, before they get to that point, because they feel the pressure, and then the parents are getting the Adderall. Before they get to that point, there's something you can do with neurofeedback that, let's just call it digital Adderall. What would that be?
Frontally, you need to inhibit any of the slower content like theta or alpha. And if there's beta there already, you leave it and you suppress any muscle. But if there's not beta there, you need to train it, and that'll be frontal. And you also need to make sure that they're able to be stable. Excitation and inhibition have to balance. So you may have to balance SMR with frontal activation. Physical stabilization and executive control needs to be activated. The frontal beta stimulation that's trained is essentially turning on the salience network, which turns off the default mode network resting state and turns on the executive network, which is what you need to have active during learning. So you teach them to flip-flop between stabilize physical and engage neurocognitive. And that control can be trained fairly readily. If you don't have complications like a learning disability or autism or epilepsy or something like that, if it's ADD, attention control that you're looking for, 30-40 sessions is usually going to be adequate to gain the bulk of the control you need, assuming regular motivation and routine attendance and proper intention. It's not that the client is being forced to come in and they're oppositional or something, but a normal ADD kid can learn in 30-40 sessions how to have really optimal attentional skill sets and laser focus, and then relax. And that control over arousal vigilance ends up being something that neurofeedback has been doing effectively for decades. The Offmers did C4PZSMR and C3FC beta, and Lubar at the same time without cues did CZSMR and FC beta. Now they know if you got beta already endogenously up front, you don't train it up, but you do suppression up front. The core ability to train the ADD out of somebody and give them optimal cognitive function has been around for quite a long time. It's been optimized now with the use of qeeg to end up identifying aberrant patterns that aren't just frontal midline and central. You have temporal findings or um, out of norm tuning or something. Those things can be identified with quantitative EEG, and it adds to the time that it takes to get things straightened out. More complex things take a little bit longer time to reform. But the brain is plastic, and which is a terrible thing to call something nowadays. Oh, plastic. Oh, that's
The
not
brain is
pollution.
rubber, yeah.
It's malleable. It's formable. The brain that can control and form itself, and that
Six, 7 years
takes.
old.
Yeah.
In fact, that's who's doing it then all by themselves. Whether they know how to do it or not is another matter.
I love working with kids 7 and 9. There's just that beautiful malleability, obviously, of the instrument, the brain, but also the willingness, the curiosity of the person. But Jay, if I could just kind of jump on a comment that you made just a few sentences back in terms of, how you can, work with ADD unless there's any LD. One of the things that
it just takes longer. It takes longer is all.
Yeah, but no, I want to share some, really good news. Part of a lot of the work that I actually do is in that small little area of, ADD versus LD, and how does a disability come to be? And there's this whole, catchment where I say it's missed learning phases. It's not a learning disability. It's essentially the child just didn't have the proper attention to zone in on what were critical foundational components in maths and in reading, writing, all the, the basic three. And you can go in and target the quote unquote ADD with the missed learning phase and bye-bye learning disability. So there's all kinds of beautiful stuff that can be done there.
The frontal attention network can end up, focusing on stuff, but the Wernicke's area, giving a name, unfortunately, the left temporal parietal junction, where comprehension is at its highest level, sensory integration stacks up and then becomes more complex, and the highest level of sensory integration ends up being in the temporal lobe, and that's where comprehension happens. And if we're paying attention to the outside world, mu is suppressed, and the frontocentral mimicking or mirroring, the mirror neurons are busy seeing the outside world and relating to the outside world and mimicking it. And if something in the outside world makes sense, and the left mirror neuron, ma, 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 pa, 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 da, 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 oh, mama and papa's two different people, oh, that's the next portion of that mirror neuron loop is the central parietal-temporal. And that portion of the loop ends up giving Wernicke area the input, the differentiation between mama and papa. Now I understand that, I comprehend that. So the basis of language is being laid down on the left. And on the right side, facial expressions, the basis of affective perception and probably empathy is being laid down. So all that network's happening, and at a young age, those networks are extremely malleable. And if you have a kid come in and you see gigantic mu, they're disconnected. That mu is a disconnect from the outer world with the mirror neuron. If the mirror neuron's not engaged, mu happens, like closing your eyes makes alpha in the back of the head. So you get this big resting state at C3, C4 of mu when you're not engaged with the outside world. And it's a normal variant neurologically. So all the neurologists are thinking, geez, they're talking about mu like there's something wrong with it. You know,
How come we don't talk enough about mu? Is it simply because it's so hard to see or find? Is it all our fault? We're not educated on it. When do we talk about mu? I know the Thompsons talk about mu all the time, but who else is talking about mu except you?
Well, anybody who looks at raw EEG ends up identifying mu, and they realize that it's a reflection of the mirror neuron system. And if you look at the qeeg, Barry Sturman said the owl eye pattern with eyes open when alpha is blocked and you see C3, C4 mu, that's an owl eye pattern. It's mu. Barry didn't like the term mu. Henri Gastaut tried to dismiss SMR as just mu. And Barry took it. He was beat up with the term mu. So he doesn't like the term mu. He says owl eyes. And if the eyes are closed and you have alpha in the bottom, and that's a monkey face. So I don't care what you call it, as long as when you see it, you recognize what it is. It's a disconnection. Now, it's not a tumor. It's not a stroke. It's not an AVM. There's no bleed. So neurologically, when a neurologist sees mu, they go, normal variant. That doesn't mean anything. Well, it means something. There's a disconnect. But it doesn't mean anything is abnormal. It's a dysfunction, not an abnormality. And it's seen in 15% of the people that would be considered normal. And quite a few of those are athletes who consider it a positive dissociation. Go to a track meet and it's freaking chaos. They're throwing things over here. There's javelins flying by. There's people running in circles and round, and there's chaos. It's ordered chaos. But you've got to basically shut all that chaos off to get into your zone for your 100-yard dash or your whatever hammer throw, so that you don't throw it the wrong direction or whatever. I mean, you've got to get your head into your zone in order to optimally perform. And you can't be distracted by all this chaos. So there's a disproportionate amount of mu in elite athletes. And again, their story to explain it is that it's a positive dissociation. I attribute that term to Santiago Brand and his work with elite athletes. And he kind of recognized that for them, that this wasn't a pathological circumstance. This was actually something that they used in a positive way. So.
Here we go again. If you want to negative for certain forms of early scholastics, but extremely positive for excelling in sports. And I'm going to add art, some of these fugue zones that incredible artists go into. And I'm, classical musicians, obviously painters, but also writers. A lot of individuals, they write something and 3 days later it's like, whoa, did I do that? Did that really come out of me? Yeah. So what are you training in? What are you training out? And why?
Yeah. Well, luckily, the brain training can be guided by the individual's desires and what they want to learn and what they want to train. The clinician, therapist, coach gives them a sampler that's had the back poked out of all the chocolate, so they get to pick which ones they like. They don't have to have the maple unless they like it, so they can choose their therapy. We give them the options. I know that this and this and this and this and this can be of benefit to you, and you get to choose. There's a platter of options. In some coaching circumstances, if it's coaching to be on a team, they may have a little bit more directive as to which one to choose. But that's, again, the person's choice as to whether they want to go with what the team is saying or not. So,
can we wrap up our going back to school show with sleep? Because we're talking about all these things that you should do, and then the kids don't sleep or the parents don't enforce sleep. It's like, how much harder do you have to work if you're getting 2 hours less sleep in a night? That's what kids are getting, right? How much harder is it for them to have to learn and then neurofeedback and all this other stuff? Because the parents have to understand that, first of all, right?
What I would suggest is let's look at some data. This is the theta beta ratio data. 1999, this is the clinical group. This is the normal comparison group, the mean and standard deviation. So you can see that the standard deviations didn't even touch. So they had a really powerful effect size, the ability to separate one curve from the other. Their effect size was approximately 1.8, which is a tremendously powerful effect size. 95 to 98% accurate, determining which group you were in by looking at the theta beta ratio. But across time, the data has fallen apart. And now the clinical group and the normal group means and standard deviations overlap so much that their effect size is 0.2 to 0.4, which is basically overlapping curves. You can't differentiate one from the other. What happened? 2 hours less sleep per night. 2 hours less sleep per night. Pay attention to sleep hygiene. Get a sleep hygiene handout from your local sleep lab. They'll be happy to give you one. Make sure the room is dark, that they don't have media in the room. They go to bed and they lay there and they're going to text with 5 friends.
Yeah.
Well, friend 1 sends out a text that wakes up 4 others. Yeah. And one of those is going to respond, and that'll wake up 5 again. So this conversation goes on and eats up a few hours into the evening, and somebody will get up early and respond to something that was last night when they didn't respond. All the emails come in the morning, and your phone beeps. The media in the room is a mistake. It's not the only mistake, but it's a big mistake. Time of the last meal, how much exercise, when. Sleep hygiene is important. It's not just taking a shower before you go to bed.
Yeah, I'd say all of that actually absolutely pales to the major issue being interactive technology in the bedroom and close to bed. We talk about obviously the loss of time, but looping back to arousal, the level of arousal, the temporal expectancy in terms of texts and responses, the blue light, melatonin production. I can literally talk for hours on this. If people take nothing from this show but this, going back to school, have everybody, I'm even suggesting for parents, minimum of 1 hour before your head hits the pillow, all devices should be off. And if you have any type of a sleep issue, it should even be more conservative. Whether you have a little bit of protein or you're in your belly, how light, the lights in your bed, all of this is absolute minutia in comparison to the effects of interactive screens and arousal before trying to go to sleep.
My Aura Ring sends my Apple Watch a message to tell me that it's an hour and a half before bedtime, and I should start to wind things down.
Yeah.
And prepare for sleep. And then it gives me another warning about 45 minutes before I'm supposed to actually be, in bed. That it's time to prepare, and that winds things down. Now, it also has the possibility of listening to Babbly Brook and Rain and a little self-coaching for breathing patterns. I mean, there's all sorts of other things that are built into it to end up assisting with winding down. Yeah. And these things are all very useful. There's some fabulous technologies that can help with it. You don't have to have the technologies, but sometimes it ends up being a good thing to have your ring tell your watch that you should get the hell off the internet and wind it down for the evening, and then and
But
then
again,
really
you know,
wind
do
it
you,
down.
do you need the wind down routines if you turn things off sufficient time before? Because our biology is kind of designed to wind itself down if we give it the space to do so, if we listen to it. Yeah. It's a big debate, you know, tech against tech versus tech helping us not need tech.
Well, the software packages that will change the mix of red and blue on your screen. So in the morning it's more bright and blue, and in the evening it's tempered down and it's more reddish. And it doesn't like look, oh my God, they turned on the red now. You know, it's a subtlety, but it's an important one. And so there's some technologies that can be used to our benefit in this area.
May I introduce a very, very classic piece of technology? Yeah, I'm going to get a bit humorous here. One of the things I recommend for individuals who just, based on their jobs or a certain, you know, stage that they find themselves in life, they're just working too long, too hard, and there really isn't a choice. And we have to acknowledge that. It's really easy for me to preach here, but you know, I've been through this as well. I recommend, and with a wink at all the grandmothers out there, I call them granny glaucoma glasses. I recommend that people go down to a pharmacy that's close by a hospital where they actually perform eye surgeries and get those wonderful full band, you know, no light gets in. They're always brown, orange, red glasses that do not allow certain spectrums of light in. And if you need to work on your computer late at night for whatever reasons, get yourself a pair of granny glaucoma glasses. And the reason why I say that is there are a lot of things that are sold online. They're not vetted. They claim they do this, they claim they do that, but go to a true medical source.
Jay, real quick, if it was 20 years ago, why would I care about the theta beta ratio?
Because it was diagnostically significant. It would identify the ADD kid from the normal kid with a simple electrode on CZ, couple of electrodes on the ears. You measure the ratio, boom, you got your diagnosis. That was the effect size. Again, the ability to separate the diagnostic curve of ADD from the diagnostic curve of normal kids. And you could see the effect size plummets, and it's down into the random flip a coin range. And if it's flipping a coin saved me the putting on the electrodes at CZ in the ears and the goop, I'll just flip a coin and to give you your odds. I mean, there isn't the ability to differentiate anymore. And it's not like the ADD group got great. I mean, if you couldn't differentiate because they got better, it'd be a great deal. But what we've got is everybody's got the ADD look now because 2 hours less sleep per night gets you a drowsy state. Rusty Turner and I were remarking now quite a while ago, it's hard to find a 10-minute EEG with the eyes closed that doesn't fall asleep. And vigilance modeling, which is a particular analysis technique used in Europe specifically, does 10-minute eyes closed EEGs. The first 5 minutes, they expect you to stay fairly well awake. The second 5 minutes, they expect some light drowsing. Well, you get people falling asleep before the 5-minute mark. And in a sleep lab, that's a failure of a multiple sleep latency test. You fell asleep so fast, you've got something wrong with your sleep at night. You've got to go get a sleep test. So we've got more referrals out for sleep testing because people qualify. They literally cannot stay awake. And in class, if you can't stay awake, you're going to look awfully inattentive.
Dr. Mari Swingle, Jay Gunkelman, all the little kiddies out there and parents having their kids go to the first day of school. We hope we've helped on this episode of the NeuroNoodle Neurofeedback Podcast. We thank you all for watching and listening. Adieu.
Bye.
The NeuroNoodle Podcast is supported by listeners and businesses just like you.